Hi guys, today I am about to explain a subject that is quite interesting. Um, if you pay attention within the next 1 hour, you'll be able to understand and interpret ECG like you never did before, even after your 6 years of medical school. So, today we'll be talking about something very, very important. Oh, come inside this mic. Come in here. Oh my God. No way. So we'll be talking about something very, very important. We'll be talking about what we call the ECG. That is sick. Okay, good. Record. So today we'll be talking about something very, very important, something very, very misunderstood, which is known as the ECG. Now, before we talk about the ECG, we need to talk about the organ. So the organ we are talking about today is the organ which we call the what? The heart. So the heart is something that is found inside the chest, right? So the heart is something that's found inside the chest, and usually the heart is divided into two sides, right? So we have the atrium here, and then we have what we call the ventricle here. Now, why is ECG important or an electrocardiogram important? An electrocardiogram is important because we have so many diseases of the heart. This is why an electrocardiogram is important. Before the coming of an electrocardiogram, it was quite difficult to understand what heart problem or heart condition a patient might have. Let's say, for example, you see a patient is holding his chest, is having chest pain or something. You cannot really say what is the problem actually just by clinical diagnosis. And ECG helps us to do what? To make our diagnosis easier. For example, like myocardial infarction, or maybe a patient has extrasystole or atrial fibrillation, or whatever have you. With the help of an ECG, we can now like understand and even pinpoint the place in which there is a problem in the heart. So this is the organ of the heart. Usually the heart is divided into two sides. We have the atrium and then we have the ventricle. Usually the atrium is significantly smaller than the what? The ventricle. So we have atrium here and then we have ventricle. The atrium is usually significantly smaller than the ventricle. So if you're having a very good heart, if you have a very good heart, and then there is contraction in the heart, if there's contraction in the heart, and you have a very good heart, this heart, for example, so you will have something that looks like this. You have your P, you have your Q, you have your R, you have your S, you have your H, and you have your T. So this is known as your P, this is known as your Q, this is known as your R, this is known as your S, and then this is known as your what? T. Now, if you, I want you to pay close attention to what I am about to say, because if you pay close attention to what I'm about to say, you will be able to easily diagnose whether a problem is coming from the atrium or whether it is coming from the ventricle, because this is very important in our ECG. So usually we can divide this ECG, this diagram, this one contraction of the heart, we can divide it into two sides. We can divide it into here, which is an atrium, and then we'll divide it here, which is the ventricle. Now, if you see this box number A is significantly bigger than box number V. Why? Because the atrium here, as we can see here, is significantly smaller than the ventricle here. Now, if one might ask, why is this important? Why am I showing that this side shows the electrical activity that's going on here, and then this side shows the electrical activity that is going on this side? Now, the reason why I am saying that is because, now I will show you. Let's say we have an ECG, for example, and the ECG looks like this, and then you have your normal QRS complex. The ECG looks like this with normal QRS complex. ECG looks like this, normal QRS complex, like this, right? Now, if we see that the QRS complex is normal, it's normal here, and then here is normal, it's normal, right? But here we can't really see clearly P waves. Now we can identify if the problem is an atrial problem or if the problem is a ventricular problem. Now let's say we have another image, for example, this one. Instead of P wave, we have something that looks like this, and then we have QRS complex, and we have something that looks like this, like this, and then like this. So if we have normal QRS complex, but here it's not like the normal P shape that we are supposed to have. Now we can identify, is this an atrial problem or is it a ventricular problem? So as we can see here, the ventricles are absolutely fine. But here we have something that does not confine with the norm here. You understand? So now we can understand that this is an atrial problem instead of a ventricular problem. Now there's something important about ECG. If you can define whether it is an atrial problem or a ventricular problem, your problem is half solved in the interpretation of the ECG. Our today's class is for us to be able to know whether it's an atrial problem or a ventricular problem. Now, if we can divide it into that, then we can now know other problems that comes under the atrium, sub problems that come under atrium, or sub problems that come on sub ventricle. So it makes our diagnosis easy for us. So let's say, for example, we have a diagram which is contrary to this. Usually QRS complex is beautiful like this. This is P, this is QRS, and then this is T. Mine is not so beautiful today. So this is your QRS complex. This is your QRS complex, right? So let's say we have an ECG that doesn't have the shape, and then we have something like this, like this, like this, like this. And then we have some tiny P waves hanging somewhere here, somewhere there, somewhere here. Now, if we see something like this, we obviously know that this QRS complex doesn't look like the one here. So we can define that, oh, we have a ventricular problem on this ECG, right? Or if we have something that looks like this, like this, like this, like this, like this, maybe some P waves jumping here, there, jumping here, and there, and there. So we know that this is a what? Excuse me. This is a ventricular problem rather than an atrial problem. So this is our goal for today, for us to be able to define, is this a ventricular problem or is this an atrial problem? So this is the topic we'll be talking about today. By the way, I didn't introduce myself. My name is Dr. Kakarama Isa, as you can see here. So this is the topic of content. This is your normal. This is sinus tachycardia, bradycardia. I know most of you can read, so I won't go into that. So let's move to the first thing here. Okay, this is artificial intelligence. Calm, calm, calm. Okay, great. Calm, calm, calm. Okay, good. So the first thing we need to know if we're studying any pathology is for us to be able to explain what is the norm. Now, if we have the norm, then if we have a pathology, we can put them side by side and then we can compare. Once we put them side by side and we compare, we can see the difference. Okay, there's some deviation here, there's some deviation there. Then we can identify the problem. So this is what we are trying to do here. I advise anybody that really wants to understand ECG should get a normal picture of an ECG. What we have here is a sinus ECG. This is a normal ECG of a patient. So in every ECG, there are what we call, okay, in every ECG we have, I'm coming. It's usually a 12 lead ECG. So you have 1, you have 2, you have 3, you have 4, 5, and then here you have your 6 chest leads, right? So usually the ECG is divided into 6 sides. So we have here, this side is called the limb leads, and then this side is what we call the chest leads. It's called the chest leads. Now, Someone might ask, why is it that we have 12 leads on ECG? Why do we have 12 leads on ECG? The heart is a small organ, although it's a small organ, but the reason why we have 12 leads of ECG is for us to see each position of the heart, each position of the heart. So when there's a problem, we can know whether it's coming from the lateral side of the heart, or when there's a problem, we can know whether it's coming from the inferior part of the heart, or when there's a problem, we can know whether it is coming from the superior part of the heart, or when there's a problem, we can know whether it's coming from the inferior part of the heart. This is the reason why we have a 12 lead ECG, usually a 12 lead ECG. On every ECG, usually the lead 2 is the best lead for us to start checking the ECG, the lead 2. Usually, the lead 2 will be placed down here on the ECG. Now, the reason why we take this picture and then we place it down is because the heart is positioned this way, right? This way. But although there is some special cases where people have dextrocardia where the heart is positioned this other side, but for normal individuals who are not Arsenal fans, the heart is placed this way on this position. So the heart looks this position. So the correct way of looking at the heart is usually from the lead 2, because the lead 2 sees the heart from this position. If you look at this ECG, you see that they are standing upright. Now, if you look at something like, let's say, for example, like V1, you see that they are standing what? This way. That means that it is looking at the heart from an opposite direction, right? This is what it means. So this lead 2, we usually bring it here so that we can see what is going, the electrical activity that is going on the heart. Electrical activity. So usually on the normal ECG like this, we will usually have like 3 contraction each. 3 contraction of the heart. This is 1, this is 2, this is 3. So 1, 2, and 3 also. 1, 2, 3. So this is for lead 1, this is for lead, this lead 1, this is lead 2, and then this lead 3. Here we have AVR. So we have 1, 2, 3 contractions. Same also on V1, we have 1, 2, 3 contractions. So usually lead 2 will be brought down here. The reason why lead 2 is being brought down here is that from 3 contractions of the heart, right, we can't really know whether there is a problem. So with usually the standard is from 5 contractions. From some books say from 5, some say from 7 contractions. But I prefer the later, which is from 7 contractions. So it means you have 1 contraction here, 2, 3, 4, 5, 6, 7. But the longer, the better, because there might not be problem on the 7th one, but maybe on the 8th one or on the 9th one. But usually we bring lead 2 here so that we can know if there is a problem inside the heart. So on every ECG, where do we start from? The first thing we start from on every ECG is to know whether it is what? Sinus. Is to know whether it is sinus. If this is the normal heart, this is the normal heart. Here we have what we call the SA node. SA node. And then here we have what we call the what? AV node. AV node. And then here we have what we call the what? Purkinje fibers down here. Purkinje fibers, and then it goes into the ventricle. Here is atrium, remember, here is ventricle, right? So if the SA node is functional, we will see something that is pretty like this. Now, this we will first see a straight line. So if SA node is functional, SA node has what we call automaticity. It is the ability of the heart to generate electrical impulse by itself. The heart is being able to generate electrical activity by itself. So if the SA node is functional, what we are going to see is that this is the way, we first see a straight line first. So when the SA node generates electrical activity, this atrium is going to contract. So on the contraction of the atrium, we see impulse go up and then come down. So once we see impulse go up and come down, then After the atrium contracts, this electrical activity comes to the AV node. And then the AV node receives this signal. Once the AV node receives this signal, it depolarizes the ventricle. Then the ventricle does what? It contracts. If you watch very well, you can see that the contraction of the atrium is significantly smaller than the contraction of the ventricle. The contraction of the ventricle is bigger than the contraction of the atrium. Why? Normal logic, just because that the atrium is smaller than the what? Ventricle. So that's why it's like that. So sinus simply means that what? The P wave is what? There on the ECG. So we take this ECG, I say we come to what? We come to what? Lead 2. So on lead 2, this, we see the straight line here, and then we see what? This P wave, it goes up, and then we see this ventricular contraction. So this one that is QRS, that is tall like Burj Khalifa, if you see something like this before each QRS complex, then we will know that the ECG is what? Sinus. But let's say, for example, now we see something like this, P, QRS, and then here we see T, and then we see P, QRS, and then here we see T, and then we see, maybe we don't see anything, then we just see QRS, and then here we see T. Now, for the fact that we have seen one P wave here, we have seen another P wave here, even though we don't see another P wave here, we still say it is what? Sinus. It's sinus. Let's take another example. If we take another example, let's say we have something that looks like this. Now, if we watch here closely, some people might come here and say, oh, maybe this is P wave. But how about this? Maybe it's also P wave. Maybe it's also P wave. Obviously, it's not. P wave, usually, it has a very good morphology, right? It looks like this. Usually, it's two small boxes here. So, this is P wave. P wave usually should be uniform. It shouldn't be multiple, triple P wave in between two ventricular contractions. Doesn't occur like that. In some cases, it occurs, but once you see something that does not conform to the normal here, you should immediately open your brain and know that there's something wrong here. This is what I'm trying to get. So usually, if you see something that looks like this, that looks like this, that looks like this, some abnormal contraction, it is not what? Your P wave. The next thing we have to know about ECG, the first thing we talk about it is whether it is what? Sinus or non-sinus. So if we have something like this with P waves like this, so we know that it is sinus. But if we have something, for example, that is just plain, we have QRS complex, and then plain with QRS complex, and then plain with QRS complex. This is what? If there is no P wave before this QRS complex, it is known as what? Non-sinus ECG. If we take another example of another non-sinus, let's say, for example, you have something like this QRS complex, like this QRS complex, like this QRS complex. Now there is no definite P wave here. So this is known as also what? Non-sinus. Even though if you have something that looks like this with QRS, like this QRS, like this QRS, like this QRS, it is known as what? Also non-sinus. As long as there is no P there. This P, this P, this P, this P. This is known as what? Non-sinus ECG. Now, we move further. The next thing we have to know is to know, after we check if the ECG is sinus or non-sinus, the next thing we need to move to is sinus. If it's sinus, the next thing we need to move to is regularity. Like regularity simply means that the distance between the QRS complex, this distance here, if it is equal, of equal distance, right? If it is equal, then we say it is what? Regular. If the distance is not equal, we say it is what? Irregular. Normal logic. So how do you do it? One, you do it by counting the number of big boxes. 1, 2, 3, 4. So here 1, 2, 3, 4. 1, 2, 3, 4. So we can see that on this ECG, every normal ECG should have a regular type of what? Should have a regular RR interval. They call it RR interval because this is Q, R, and then this is S. So R is here, R is here. So if the distance is same, then we say it is what? Regular. If the distance is not the same, we say it is what? Irregular. As simple as ABC. So sinus, regular. The third thing is heart rate. To calculate the heart rate, there's a simple formula we use, or if you have an ECG, usually the modern days ECG, you will see the heart rate there. They will put heart rate like 70, they will put heart rate like 80, 90. It will be on the ECG itself. But if you want to calculate the heart rate, the simple formula is heart rate, HR, is equals to 300 divided by RR interval. RR interval is just the number of big boxes you have here. So for example, like this one, we have what? 4 big boxes. So it will just be 300 divided by what? 4, which will give you what? 75. Normal heart rate is between 60 to what? 100. Bigger than 100 is known as what? Tachycardia. Lesser than 60 is known as what? Bradycardia. So the person have low heart rate, either low heart rate or high heart rate. So what I just explained is what we basically have here. What I just explained is what we basically have on the chalkboard right now. So if you watch very well here, here we have what we call a regular ECG, and then here we have what we call an irregular ECG. How do we know it's regular? Because of the RR interval is what? Equal. Why here we can see that, okay, we have 2 boxes here, we have 3 boxes here, we have 2 here, we have 2 here, we have 2 here, we have 3 here, we have 2 here, you have 2 here, we have like 1.5 here, we have 3 here. So here is irregular. Meanwhile, here is 2, 2, 2, 2, 2, all 3. Right? So the next thing we want to move to is what we call sinus tachycardia. What does it mean, sinus tachycardia? From the word sinus, it means that P wave is present. And if you listen very well, I explained that normal heart rate is between what? 60 to what? 100. So if you have an ECG whereby the P wave is present, everything is fine, everything is good, but the heart rate is over 100, it is known as what? Sinus tachycardia. That means P wave is present, but there's what? Increase in heart rate. Now, if we watch very well, how many boxes do we see here? Now we see 1 here, we see 2 here, and then here is like 0.5. So it's like 2.5, right? 2.5. So 300 divided by what? 2.5. So that means that what are we having here? That is 300 divided by 2.5. 1 minute. So 300 divided by 2.5 is 120. So on this ECG, we have a heart rate that is greater than 100. So it's known as what? Sinus tachycardia. The first thing here is P present. It is sinus. The second thing, it is irregular. It is obviously regular, right? 2.5 boxes in between. So 300 divided by 2.5 sinus tachycardia. That's what we have. We have what we call sinus what? Tachycardia. Now we'll move to the opposite of oh my god. We move to the opposite of what sinus tachycardia is, which is what? Sinus what? Bradycardia. Sinus bradycardia, from the word brady, it means what? Lower heart rate. So on this ECG, we can see that how many boxes we have. First of all, is it sinus or non-sinus? Obviously, we have P wave here before QRS complex. P wave here, P wave here, P wave. So it is sinus. The second thing is it regular or irregular? 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8. So we have 8 big boxes in between, right? So sinus, it is regular. The next thing we calculate heart rate. So 300 divided by what? 8. 300 divided by 8, if I'm not mistaken, it's around 40. It's 37.5. 37.5. So 37.5 is less than 60 because normal heart rate is between 60 to 100. So less than 60, it is known as what? Bradycardia. So here I have a tax. I have a tax for you. Now let's do this together. So the first thing we need to check is there P wave. Obviously, we can see P wave. These small things before each QRS complex. These are what? P wave. Is it regular or irregular? The next thing. So we have here how many boxes? 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. So there are 4 boxes in between. 4 boxes each. So 300. Then first of all, sinus. Second, regularity. The third thing we are going to calculate heart rate, which is going to be 300 divided by what? 4. Because 4, 4, 4 all true. So 300 divided by 4, what do we have? We have what? 75. So this is a normal sinus ECG. The next one is P wave here, we have P wave here, we have P wave here, we have P wave. So it's sinus. So 1, 2, 3, 4. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. So 300 divided by what? 5. It is also regular. So it's like 60. So it is still a what? Normal ECG. This is the normal ECG we have down here. Now we are going into pathology. We spoke about sinus tachycardia. We spoke about sinus bradycardia. Now, before we even move to the next pathology, which is supraventricular tachycardia, I want to say a few words about sinus tachycardia and sinus bradycardia. Sinus tachycardia occur in normal people, normal individual. Let's say, for example, especially when you're emotional, when you have anxiety or something, it might occur. You can feel your heart beating, boom, 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 boom. A very good example is like when you have exam, right? When you have exam, your heart rate increases. Or maybe, for example, when you go to the gym, right? When you go to the gym and you start running, you see that there's increase in your heart rate, right? So this is known as sinus tachycardia. Or for example, a very good example that I think that you will actually understand is like, okay, sorry, when you meet your crush outside, right? All of a sudden, you don't know your crush is outside, and then you just you meet your crush. Of course, your heart rate begins to increase, it begins to rise because this is known as sinus tachycardia. It's normal. It's just a normal physical physiological issue. It's not a problem at all. An example, very good example of sinus bradycardia. Sometimes it occurs as pathology, or sometimes sportmen also have sinus bradycardia. Sportmen. So the next thing we are moving to is what we call supraventricular tachycardia. When you hear the word supraventricular tachycardia, What we are talking about is that it is coming above the ventricle. So hence it is known as what? Supraventricular tachycardia. So this is your this is your heart. No, not your heart. This is heart. And then here we have what we call the SA node. And then here we have what we call the AV node, right? So anything that is coming above ventricle, this is the ventricle. It is known as what? Supraventricle, right? So if a tachycardia is coming above the ventricle, it's known as supraventricular tachycardia. Now, how does supraventricular tachycardia occur? Actually, it looks like something like this. Let's say the first ECG, we have something like this: PQRST, and then PQRS what? T, like this. And then the next one is like this: PQRST, PQRS what? T. Then here we have something like this. PQ, right? And this, I draw this again one more time. So we have something that looks like this: PQRST, PQRS. So here is PQRS what? T, PQRS what? T, PQRS what? T, PQRS what? T. So we now have the next ECG. It looks like this: PQRS what? T, PQRS what? T, PQRS what? T, PQRS what? T. Then the next ECG now looks like this. Now, I want to explain something to you guys. Let's say the distance between here to here is just 4 boxes. 4 boxes. And then the distance here is now like two boxes. Two boxes. Now the distance here is now like one boxes. One box. One box. Now here we have your T wave here, you have your P wave. You have your T wave here, you have your P wave. Now, here we have 4 boxes. So the heart rate is going to be what? 300 divided by 4, which is 75. Here we have 2 boxes. The heart rate is going to be what? 150. And then here we have 1 box is 300 divided by 1, which is what? 300. Now, what I'm trying to say is that the faster the heart rate, the narrower the RR interval. The RR interval. Here 4, here 2, here 1. So if you watch very well, we have your T wave here, and then you have your what? P wave here. T wave and P wave. Now, if you watch very well, when the heart rate becomes faster, which is you have 2 boxes here, the T wave and the P wave, they come closer together. And then finally, when it's 1 box, what happened? There is what? Fusion. The P wave is inside the what? The P wave is inside the T wave. So this is this form whereby you just have T wave with narrow QRS complex like this. It is known as what? Supraventricular tachycardia. It's a pathological problem. It's a pathological problem. So this is what supraventricular tachycardia. We have our T wave, our T wave, our T wave, our T wave, no P wave. So it is what? Non-sinus. The second thing is that it is usually what? Regular. So here is 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. So it is what? Regular, right? And since it's tachycardia, we have what? Tachycardia. Here, actually, it is approximately 3, but it's not actually 3, like 3 boxes in between. So 1, 2 is almost 3, but not 3. But I just rounded it up to 3. So here we'll be having 100, maybe like 105 or 110. You get, right? So the first thing, sinus or non-sinus, obviously it is non-sinus because we can't see P wave. Regular or irregular, it is what? Regular. And the third thing, it has tachycardia, which is what? 105. Likewise, also here, you see they indicated that the P wave is buried inside the what? T wave. Oh my God. Okay. Now, the next thing I want to explain is what we call paroxysmal supraventricular tachycardia. Now, with paroxysmal supraventricular tachycardia, paroxysmal simply means that there is what? Sudden onset. Paroxysmal. It's just a big word the white men throw to confuse you. So, it is known as sudden onset. So, what usually happens in paroxysmal supraventricular tachycardia is that you have a normal ECG. here, which is here, and then all of a sudden you have your what? Supraventricular tachycardia. So normal ECG plus supraventricular tachycardia is known as paroxysmal supraventricular tachycardia. But somebody might ask, what is now the difference between, oh, like having this kind of thing from a normal individual? All of a sudden, one doesn't just have tachycardia like that, just like that, sudden onset. There has to be something, it's a gradual increase. Usually, physiologically, that's what I'm trying to explain. You have a gradual increase in heart rate, not just spike. So this is pathological, hence this is known as paroxysmal supraventricular tachycardia. For supraventricular tachycardia, the main method of the treatment of supraventricular tachycardia is adenosine. And also we use adenosine in the diagnosis, not just the treatment of supraventricular tachycardia, also in the diagnosis of supraventricular tachycardia. And we use it to differentiate, does a patient have supraventricular tachycardia, or does the patient has what we call atrial what? Flutter. Because sometimes on the ECG they look alike and we can't really differentiate. Is this supraventricular tachycardia or is this what? Atrial flutter. So we administer adenosine to such patient, and then if it's supraventricular tachycardia, good, the patient is cured. But if it's atrial flutter, then we know we need to administer some other treatment. This will be all for today. Wait for part 2. Thank you. Oh my goodness.